So welcome back, everyone. Again, this third presentation for the day is the co-occurring physical and behavioral health conditions in people with intellectual and developmental disabilities. So again, the housekeeping issue are updates, the attendees, everyone will have their lines muted and their video muted. Please use the chat function for comments or technical issues, and questions for Dr. Stobbe can be directed under questions. And we will get to those at the end of the presentation as we have time, or we'll be able to track the questions for follow-up afterwards. His slides are available under handouts. And again, this is being recorded. Another reminder that we'll get to, remember, we want to get your feedback. So there will be an upcoming evaluation for all these sessions. So for this presentation, I'm going to hand off to Dr. Sasha Waring to introduce the presentation. So Dr. Waring is the Senior Behavioral Health Medical Director at Molina Healthcare of Washington and a child, adolescent, and adult psychiatrist. So Dr. Waring.
Thank you, Stephanie. Hi, everybody. So I'll be brief. I want to get to the good stuff from Dr. Stobbe here in a moment. So it's my pleasure in turn to introduce Dr. Gary Stobbe, who, among other things, is a clinical associate professor at the University of Washington, where he also serves as medical director of the Adult Autism Clinic. His original medical background is in neurology, but he has clearly branched out substantially from there. He has been instrumental in starting and developing the Centers of Excellence in the state of Washington for the early identification of autism. He's an expert in diagnosis and treatment of autism in people of all ages. And then I personally have had the privilege to work closely with Dr. Stobbe over the last year and beyond as we work together across all entities, but clinicians, Centers of Excellence, payer side, and regulators and legislators to really try to advance and enhance the system of care for people living with autism. So Dr. Stobbe, take it away.
Thanks, Sasha. Can you hear me okay? All right, and hopefully you guys can see my screens, and I appreciate the opportunity to speak today. And yeah, when I meet with residents, I often say, don't predict where your career is going to be 20 years from now, because I certainly didn't go into neurology thinking that I was going to be working primarily in neurodevelopment. But I had some early events with individuals that really led me to appreciate how interesting and just downright cool so many individuals with developmental disabilities are, and it was really fun working with them and their families, and how often they're misunderstood and how often there is difficulties with access to care. And I have a strong interest in equity and healthcare systems and access to care. So I appreciate this opportunity, because one of the things is there's never going to be enough specialists to do the type of work to work with this population. So I love the opportunity to talk to primary care providers and others on how to better interface with individuals with intellectual and developmental disabilities. So, I've got no disclosures today. Objectives for this talk are really to become familiar with some of the more common co-occurring physical and mental health conditions seen in people with intellectual and developmental disabilities, and highlighting some of the barriers to doing evaluations, coming to diagnosis, and making treatment plans, and some of the challenges in these, or some of the common treatment strategies that are used for this population. So a couple of high-level points. People with intellectual and developmental disabilities across the board have a kind of increased incidence of medical and behavioral health concerns beyond their developmental conditions. There's increased rate of hospitalizations for this population, increased emergency department visits, life expectancy is reduced. And when you look at it, there's a lot of issues that probably lead and predict these facts. The difficulty in accessing healthcare in general for this population. They're primarily Medicaid population, especially in their adult years. There's a limited number of providers that feel confident with expertise in working with this population. And then many of them have a lot of difficulties with communication with providers, with their family members. And so it's often very challenging in how to identify whether there is a new physical or mental health condition in this population. Those difficulties lie both at home as well as when they come into your office for an exam. I want to frame this with a couple of cases just to kind of think about, the developmental disability population is very broad, lots of differences, and so it's hard to kind of pick just a couple cases to represent. But these are a couple nice cases that I thought I would highlight. So this first case is actually an individual that does not have an intellectual disability. So this is a person with autism, a 18-year-old female who went through a lot of mental health issues even in her preteen years. She was admitted to the hospital for suicidality, was at that time diagnosed with obsessive compulsive disorder and major depression, did not have a autism diagnosis at the time. And this is something that we'll see in some of our individuals that do not have intellectual disability, where the developmental disability can be missed, and it's primarily these mental health diagnoses that are being made. She ultimately got diagnosed with autism in her teen years, and one of the things that really stood out in her evaluation for autism, they did a full intelligence scale IQ workup, and she had this one of the classic things that can be seen as this splintering of skills, where she had some areas, in her case, her processing speed was very low, abnormally low, yet her working memory was higher than average. So a 50-point difference, which of those of you that know IQ testing, that's very unusual, but not that unusual in this population. So she was somebody that had verbal IQ above 100 as well. So when she presented in the office, she was somebody that in initial conversation, you wouldn't necessarily pick up on some of these differences. When I first saw her, she was doing much better. She had been able to, unfortunately through some of the her big needs around mental health, she was able to access some counselors that were working with her in a DBT program. She had been placed on medications, including aripiprazole, bupropion, and duloxetine, so a pretty complex regimen. She had what you could see and relate to her autism was flatness to her affect. It was difficult for her to get across some of the real issues of concern. I got on her good side with a little simple thing I've learned over the years, which is asking if the lighting is okay in the room. And that really stunned her. I was the first provider that had ever asked her if she felt comfortable in the room, and it really kind of got me off on the right foot with her. This next case is probably the even more challenging type of case that is going to be really a focus of today's talk, which is this is an individual that when I first met him, again, it was around age 19, so right before turning 20. This is an individual with autism who is minimally verbal, and also has a diagnosis of intellectual disability as well. He had pretty significant disruptive behaviors when he was younger, aggression and property destruction. And then kind of out of the blue, these behaviors came back. They had been gone for a number of years. They came back and were really stumping mom as to what was going on. Why were these behaviors re-emerging? And in the visit, I could tell, and this mom agrees with this, he had better verbal comprehension than his expression. And so I was very, felt it very important to have him in and talking to mom. I was in some ways talking to him as well, and brought up this point at the time that we realized that this was somebody that what mom had settled in with his daily routines he'd kind of grown out of, but he'd never been able to express this to her. He didn't, but he certainly, when I brought up some new, more adult activities, I could sense that he was getting excited talking about those. And mom saw this happen, and she was able to then kind of change his activities and the focus of his activities with his caregivers. He started participating in a number of music-related activities, attending classes at a program, the Alyssa Burnett Adult Life Center, that we run through Seattle Children's. We did feel that he was depressed at the time, and we felt that the depression was manifesting in some of these disruptive behaviors. And so he responded to kind of a combination of medications targeting depression, and then also these kind of changes in his lifestyle. And he's done quite well in recent years as a result of really this change of focus on his lifestyle activities. So I give those couple cases as framework. I also give this slide as framework because I think I've been doing this work for a long time. I host a lot of panels that are made up of that include self-advocates, individuals that identify as autistic. And I love asking the question to adults that are self-advocates, what would you do, what would you recommend to providers and parents maybe in the teen years? What would you do, what could they do different? And two recommendations always come to the surface. One recommendation is, I wish you helped teach me to self-advocate at an earlier age. And the other is, I wish you wouldn't always focus on the negative. And that I have to resonate in my head all the time, and I've gotten better at it. You know, we're limited in our time, and we're very focused on trying to identify the problem. But it's really important, I think, especially with individuals, to highlight the positive, and with the parents and families to highlight the positive as well. And this is a slide that has been, that we've handed around to a lot of people on some of the positives that are seen in the so-called superpowers that are seen in autism, and as well as others with intellectual and developmental disabilities. And this is often, these strengths are going to be what are going to pull you out of a crisis, especially if it's related to mental health. All right, so before I go into some of the specific medical conditions and behavioral health conditions, I wanted to just take a couple slides to think about how the definitions of these populations, because it is kind of confusing. You know, we use the term developmental disability as this broad category, that if you have a chronic disability that originated in childhood, so up to really age 21, and it substantially impacts functional ability, then that is kind of the definition of a developmental disability. And you want to transition from the term developmental delay kind of between age 5 and 10, as the individual is kind of declaring themselves that this isn't just a delay. This is something that is going to be with them through their life. Intellectual disability makes up a large portion of this as a subset of developmental disability. You know, the term mental retardation has fallen out of favor, was replaced really by this term intellectual disability. Rosa's law that was passed, so all federal documents, mental retardation was taken out of it, was intellectual disability was used in its place. And again, this is really characterized by the limitations in the intellectual functioning, reasoning, learning, problem solving. But it again has to have that significant limitation in adaptive functioning and occurring in childhood. When you get to autism spectrum disorder, it's important to note that about somewhere maybe around half of individuals that meet criteria for autism also meet criteria for this intellectual disability diagnosis. And so we think of autism spectrum disorder as a subset of developmental disability, but not necessarily as a subset of intellectual disabilities. They sometimes co-occur. I think these got a little bit confused when DSM-5 came out with their neurodevelopmental disorder category. So it's just important to recognize that DSM-5 has definitions in which intellectual disability was defined as intellectual developmental disorder. So they kind of fancied the name up a little bit. Autism is included here, ADHD, some of these more specific communication, motor, and learning disorders are categorized here. And again, it's important to note that not everybody that meets developmental disability has an intellectual disability. I talked about autism, that upwards of 50% of individuals with autism do not have intellectual disability. Some genetic syndromes that meet criteria for developmental disability don't have intellectual disability. Some individuals with cerebral palsy meet this category. Some of the other acquired conditions could meet this category where it's a developmental disability but not intellectual disability. So with that all said, now we're just going to kind of lump it all together and talk about these co-occurring physical health and mental health conditions. I'm not focused on the sensory disorders, which also occur at a higher level, hearing loss and vision impairment. In this population, we're not focused on that for today's talk. So let's look at physical health in this population, and we're going to focus on the conditions that the literature fully supports a higher incidence level of these genetic syndromes, sleep, epilepsy, and GI. And then we'll highlight some of the more recent data on many other conditions that have also been identified as occurring more commonly in this population. Genetic syndromes. So I think this is important to recognize individuals that might have genetic variants. And I think that the benefit of identifying if your patient or your loved one has a developmental disability, do they have an underlying genetic syndrome that is leading to this? And I think one of the reasons that this is important is individuals that have genetic syndromes are more likely to have multiple organ systems involved in as being potentially dysfunctional or functioning differently. A classic example of this, Down syndrome, with individuals that might have higher risk for cardiac involvement, higher risk for developing Alzheimer's disease, a number of other systems that can get involved in this population. And I think where this really becomes handy, if you've got an individual where you think they might have a genetic syndrome, but you don't have genetic testing, but they have maybe dysmorphic features on their exam. They might, a question I love to ask is, when did you walk? If there is significant gross motor delay, that's usually more than just intellectual disability and autism. That often points to maybe a broader syndrome underlying the condition. Certainly early onset seizures also points to potentially a broader syndrome. And this is really important if you've got an individual that all of a sudden is having new behavioral problems, to recognize that they might be manifesting with behavioral problems as their way of saying, hey, I've got pain, I've got something going on in my body, but they're not able to verbalize that to you. And so an individual that might have dysmorphic features, you might make a deeper dive into other organs to look for conditions because they are going to be at higher risk for some of these other conditions or associated. The genetics in autism has been very fun to follow. If you do modern 2020 genetic testing on population with autism, you can get over 50% now where you can identify either a syndrome or one of these micro deletions or duplications. We did and this is going to be especially if you're taking individuals with autism and that have co-occurring intellectual disability. That's going to increase the likelihood of you getting a finding that is felt to be clinically relevant. I think where we are thinking about future state for genetic testing would be some of these individual syndromes that really predict a phenotype. The hope is that we're going to get to a day where our treatments are more biologically based and more specific. We're not really at that day for most individuals, but hopefully we'll get there. I think families certainly like identifying underlying biology, so there is some advantage. Even if it doesn't change your treatment plan, it might change the approach that a family takes with their child or with their loved one. This Rafe Bernier, who is our executive, our executive director at the Autism Center at Seattle Children's up until a couple years ago, made his claim to fame with this study of the CHD8 gene, which was really cool because they were able to show if you had this gene mutation, they did a knockout in a fish model, and the fish ended up swimming in circles, having GI dysfunction and not being able to sleep. So they really replicated the phenotype, in this knockout model of a fish. And it shows that sleep dysfunction, gastrointestinal disorders, these other systems that get involved, it's not always necessarily just behaviorally based. It might be biologically based, some of these abnormalities or differences. All right, so sleep is a big one, and sleep is especially in the autism population, but sleep disorders are more common in all developmental disorders, but especially in autism. And sleep disturbance is important. It significantly increases stress levels for the family. It's an independent variable for psychiatric hospitalization. And the problems that we see, especially if we think about what has most been studied in recent years as part of the Autism Treatment Network, which is a group of centers that was created by a grant from Autism Speaks a number of years ago, have learned a lot about sleep in the autism population, and they've learned that there's actually a melatonin deficiency in some individuals with autism. And the most common problems are difficulties with sleep onset, duration, nighttime awakenings, sleep fragmentation. So less commonly do you see these other primary sleep disorders like sleep apnea or restless leg syndrome, parasomnias, but those can be seen as well. So we do go to sleep studies for a lot of these individuals. Although often we will start with some of our safe supplements like melatonin if we're seeing this to be a problem that's causing problems for the individual and the family. We do have what you will see is a heavy focus on trying not to go to benzodiazepines to assist in sleep. I think you'll see, we will tend to start with over-the-counter medications like the melatonin. Antihistamines you have to be careful with because this population is more prone to paradoxical responses to medications. The antihistamines are classic for that, where you try to make them sleepy, but it backfires on you and makes them irritable and up all night. Certainly the alpha agonists like clonidine are used and are favored by our sleep docs with this population, and trazodone, in that trazodone does not interfere with the deeper levels of sleep, is a good one to think about. We try not to go to the antipsychotic meds purely for sleep, although I think our psychiatrists and those of us that do this work, sometimes we have done that. And then gabapentin is another one to remember that's a relatively benign medication that the sleep doctors will sometimes favor. Epilepsy is very common in certainly the autism population. I think that when you look at the neurodevelopmental population as a whole, the more severe the developmental disorder, kind of this correlation with increased likelihood of epilepsy. You get all kinds of seizure types. You get generalized and partial seizures in these populations. You can see this study on EEG abnormalities showing both focal and generalized abnormalities on EEG. Again, an early onset of epilepsy around, in the 1 to 3 year old range. Think syndrome, think underlying genetic syndrome if you see that presentation. And another little pearl is to be aware of one of the favorite anti-epileptic drugs currently is levetiracetam, also known as Keppra, is not a favorite in this population. There's an increased risk of irritability and behavioral disruption with levetiracetam. That being said, I have a lot of patients on levetiracetam doing fine. So again, you can never say anything with 100% certainty in this population. You'll see the other ones that are favored are the group that are used by the psychiatrists as quote unquote mood stabilizers. So lamotrigine, valproic acid, oxcarbazepine, which is the kind of the newer generation of carbamazepine, all have some evidence of benefit in stabilizing mood in bipolar disorder, and sometimes in developmental disability population have positive effects on behavior. So getting that kind of as a secondary benefit. The other one I'd put on here is topiramate. Topiramate, not great as mood stabilizer, but it has that side effect of weight loss. And many of this population have trouble with weight gain. And so topiramate's another one I should probably list on this slide. This is a slide showing age of onset. This slide is kind of looks similar to age of onset in epilepsy in general, except it doesn't have some of the later ages of onset that you'll see in the typically developing population with like stroke and tumor and brain injury. This is more focused in those pediatric years. Most common age of onset around the time of entering adolescence. You see a little peak around entering the 20s. And I do have a number of patients in my practice that didn't have seizures until into their 30s or 40s. So that does happen as well. So something to be aware of with regards to epilepsy. And I think that this is, again, gets into when you have new behaviors that are brand new, and you're trying to rule out other medical conditions. Something that often is on a differential is like, well, maybe this is a simple partial or complex partial seizure, that could be manifesting as unusual behaviors, often remains on our differential. GI dysfunction and autism specifically has been, again, studied through this autism treatment network that I mentioned before. There was a lot of excitement about this because there's been a lot of anecdotal observations of benefit with dietary restriction at helping to improve function and behavior in autism. This is not held well in scientific studies, but what has held well is that people with autism and other developmental disabilities have higher likelihood of functional problems, especially constipation. And in autism, we think a lot of this stems from some of the sensory sensitivities, maybe a painful bowel movement that they might have had that then makes them withhold. They get constipated, they get a hard stool, they start to leak around the hard stool. It looks like diarrhea, but it's actually a bowel obstruction. And so this can be a really nasty thing, and this can really is something to always keep in mind with regards to new onset disruptive irritable behavior of maybe it's a functional GI issue. Just another area to be aware of, motor disorders, especially complex motor tics, which is, you can think of as a Tourette's syndrome variant. classically is taught as emerging in the primary school years, so kindergarten, first grade. It's a classic time to see motor tics develop. Interestingly, with the intellectual and developmental disability population and autism, you can see new onset motor tics in the teen years and later. So again, a new onset behavior might be a complex motor tic, and very difficult sometimes to differentiate from the so-called stereotypies, repetitive mannerisms, or self-stimming behavior that is seen in autism. Um, but certainly can be seen onset and might be pointing you to possible new anxiety or new stressors that might have led to this new onset tic. And just before we move on to the mental health issues, some of the recent data from large databases, Kaiser Health has been doing a good job of this especially down in California, that really identifying so many conditions that are seen at a higher incidence in this population. I think a lot of this is when you look at these things like obesity, hypertension, dyslipidemia, diabetes. The worry with that is that that this population, especially getting into the adult years, I worry about them not getting just general basic health needs met. Parents and families and caregivers, they have, only so much energy to focus on. Often basic health can be, like for instance, brushing the teeth or keeping the weight down. Often getting blood draws is hard, so they might go for years without getting blood draw. And some of the individuals, I had an individual diagnosed with a testicular cancer that it had been identified that probably it had been 5 or 10 years since anyone had seen him unclothed. So I really emphasize that, especially with the intellectual disability population or minimally verbal population, we should think of them as a small child where they need to get an annual physical. They need to keep that connection with a provider for many reasons. To get that annual physical, this population deserves all of the health screening that other people deserve, I think that just remaining familiar with the process of going to the doctor or going to a provider's office, the process of getting a blood draw, the process of getting a blood pressure check. These are things that we need to keep as common so that when they do run into a problem, there's not going to be as difficult time getting them to get an exam. And then one other thing to highlight, and I think this is a great slide to kind of transition into the mental health, is a concept in neurology that we've known in other conditions that has been coined autistic burnout in the autism population. And it's very, very similar to what we describe in the traumatic brain injury population and the multiple sclerosis population and other acquired central nervous system conditions of what we call cognitive fatigue. And this is the thinking here is that an individual with autism, to function in our dysfunctional society, that these individuals have to use more brain energy to socialize with each other, with us, to filter and screen out some of the sensory input that often is bothersome to individuals, to remain focused and be able to focus and attend. It's more brain work. And so you'll get often individuals will come home, end of the day, their neurological symptoms will be increased often, and they'll be exhausted from their day's activities. When that happens, also individuals, their irritability, their difficulty in self-managing behavior will come out more. So this is often, families will often reflect this like, oh, he does great at school, and then he comes home and he bursts out of control. Some of this is probably because they're comfortable, because they're at home, but some of this is also because of this concept of cognitive fatigue or burnout by the end of the day. All right, so let's go into some of these specific mental health issues. I think that often it will present, we will use the term disruptive behavior when we hear a new behavior that we haven't identified as to the exact cause. And so that will be a label that you might see. Some of these, this becomes the primary diagnosis, explosive behavior or disruptive behavior. But often there's something underlying it. And hopefully you've ruled out these medical conditions in this process, and then you land on, is this a primary mental health condition that is now developed in this individual? Some basic concepts around this. We can think of autism and developmental disabilities as kind of a neurodevelopmental substrate. So that enhances the likelihood of these co-occurring mental health conditions. So across the board with studies that have been published, individuals with autism and other developmental disorders are at increased risk of mental health conditions. When you're talking about like that first case I presented that didn't have intellectual disability, the second bullet point under there, that the psychiatric diagnoses delayed the recognition of the autism diagnosis or the developmental diagnosis. And then that can be reversed too. The autism or sometimes ADHD diagnosis can delay recognition and treatment of other mental health diagnoses. So this is important to recognize. And I think that with individuals with intellectual disability, the presentation is atypical usually. They're not going to come up to you say, I'm anxious or I'm depressed. You know, they're gonna come up because they've got new onset self-injury, aggression, irritability, new movements or behaviors, and that's when you need to be thinking about these potential new mental health conditions. And it is important to recognize that some of these behaviors like self-injury, aggression, could be a way that they're trying, it could have a functional component to it, that they're trying to get communication to you through this behavior. And and we'll talk about this in a couple slides. One of the things to highlight, if you wanted to invest in this, would be the this organization, the National Alliance for Dual Diagnosis, or NAD, came up with a variant of the Diagnostic Statistical Manual to accompany the DSM at the time 4, but now they came out in an updated version with DSM-5, which kind of takes into account the DSM-5 for individuals with intellectual disability. So that's something that might be valuable to you. So I think before you go down the path of, like, let's say as a med provider, like I might do, where I have access to medications, this really important to ask this question about this new onset behavior. Is it serving a purpose? Is it trying to communicate? Have there been environmental factors internally, some new medical or physical condition, or some external stressor that is manifesting in these behaviors? And this gets to the one of the primary treatments in autism and in intellectual disability is applied behavior analysis, in which the first job of these behavioral analysts is to analyze the behavior. And you'll see this done in the school districts with what's called an FBA, or functional behavioral assessment. And you'll see this done in the clinic by these ABA providers, where we say, we got this new behavior. I've ruled out as much medical as I can. I don't know what it represents. Can you help me assess? Is it triggered? You know, parents and caregivers aren't always the best at identifying if there's underlying triggers to behaviors. Now, I think that ABA therapy can still be, and this applied behavioral analysis is still beneficial in individuals where you may have already identified, yes, they've got anxiety, yes, they've got depression, yes, they've got ADHD, one of these other conditions, but I still need help with the behaviors. And so the ABA therapy teams will be involved even when we have identified other co-occurring conditions. We're often, just like you might do with an individual without a typically developing individual, outcomes are going to be best if we combine medical treatments with therapy. The literature supports the same thing with this population, a combination of a medical and behavioral approach. So in my final 5 minutes here, I'm going to rattle off, and then we're going to leave some time for questions. Some common things about psychiatric medications in the population. I'm focused on the adult ASD population for this slide. Very little evidence of what we kind of consider top tier evidence of effect. So systemic evidence of benefit is lacking. Yet, despite that lack of evidence, we use them a lot. And we do, some of this is supported because we see benefit, but some of it is because we're desperate and we don't have access to the behavioral therapist. So we still don't understand what the behavior is. So we do a lot of guessing. And I think we try to avoid polypharmacy, but it's common in this population. I think there's a lot of challenges when you're treating this population, because you might say, I think this is anxiety. I'm not sure, but I think it is. So it's very important that with the caregivers that you identify what's our target, what's the behavior that we're going to measure with this when we start this treatment with this medication. Measuring response is challenging. It's going to be subjective reporting from the observer. It's often not going to be asking the individual, do you feel less anxious? Adverse events are more common in intellectual and developmental disability population than in typically developing age-matched control groups. And always just remember regression to the mean. I think this is true whenever we're embarking on treatments, but we might have accidentally lucked out and the behavior was going to get better anyway. They often present to us at their worst point in a kind of relapsing remitting type of pattern of symptoms. And so don't overcredit medication sometimes. Keep your mind open that they might have just regressed to the mean. A few other basic principles. Often the maximal dose that we use is lower than in typically developed individuals. We try to start low and go slow if possible. We try to avoid polypharmacy if possible. I think we do a lot of work in our adult years. It kind of reminds me of the geriatric psych population too, where the geriatric psychiatrists or geriatric docs are peeling meds off more than putting new meds on. And that's something that we do in our adult autism clinic. We're trying to simplify meds as much as possible. There's nothing unique about these meds in this population. It's the same group of meds that you'll see with other conditions. There's nothing really unique. I would state that in the antipsychotics, that in the autism population, risperidone and aripiprazole, you'll see them used most commonly because they've been most studied. Doesn't mean they work better. It just means they've been studied more. We try to avoid the benzodiazepines. Using PRN medications, as much as caregivers love it, they just don't work. They work well if you're knowing you're going to an event. So I'm going to the dentist, I'm going to the airport. Then you can give it 45 minutes, an hour ahead of time. But if you're using it as a reaction to disruptive behavior or irritability, often the event is over in 15 to 20 minutes. And so you're kind of treating yourself more than anything else. Hitting a couple of highlights on anxiety. One of the things to remember is that anxiety often increases as we become more aware. And self-awareness is delayed in onset in this population. This concept of theory of mind is delayed in autism and in individuals with intellectual disability. And if you have an individual that's minimally verbal, they might still be becoming more self-aware and might then get anxiety or depression related to that emerging self-awareness. So an individual that's been doing well, development of anxiety or depression in some ways is a sign that they're developing and making progress developmentally. But unfortunately, it's often, very difficult and challenging to deal with it when it does occur. A couple of highlights on this slide. Don't forget about buspirone as a medication that can be used. We talked about avoiding benzodiazepines. The alpha agonists like clonidine and guanfacine, don't forget about them. They will sometimes be helpful for reducing irritability or impulsivity. And please don't forget about basic health needs. Physical exercise and sleep always is in there, about ways to improve anxiety and depression as well. Just as a couple things to highlight here are just how high the risk is for suicidal ideation and suicidal attempt in the autism without intellectual disability population, a real problem. With hyperactivity and impulsivity, I mentioned on the alpha agonists. I think that we typically start with stimulants because we get such a great quick answer with stimulants. It's really, they're easy meds to work with. Don't forget about interplay between anxiety and ADHD. You can often secondarily improve anxiety by focusing on ADHD and vice versa. You can, if you can reduce anxiety, focus and attention often improves as well. So a lot of interplay there. Just as we get to the final couple slides, antipsychotics, typically reserved as second line. Thankfully, we do get benefit at low doses. So we really encourage you to use very low doses to start with if you are going to be using antipsychotic medications. They are kind of a shotgun. They have a broad potential benefit, but of course, more concerning with regards to side effects. And I just included this. We don't have time to talk on these. I think a couple of highlights in bold with this population. If you have unexplained new onset severe insomnia, I'm talking about the type of 2, 3, 4 days without sleeping at all, put mania on your list as a possible co-occurring condition. And if you have unexplained new onset weight loss, significant weight loss occurring over time, put catatonia on your list as a possibility. These are things obviously you're going to want to get psychiatry involved. If you're getting into these deeper dives into the differential diagnosis. And I'll end with one of my favorite slides. I think I just put this slide in all my talks because I just like the slide, I guess. And this is just a reminder about these strengths and weaknesses, and please keep in mind to ask about the questions about strengths. And because they're going to be valuable to you to highlight on those strengths, because like I said before, it's often the strengths that are going to pull the individual out of the hole that they're in. But it's also respectful and appropriate to get to a better understanding, and you will get on the better favor of your patient and your family and caregivers if you don't forget about this part. And this is an interesting study, and I have my list of studies that I've highlighted. This one by Koenig in 2017, just saying, hey, these special interests that we're trying to get people to be less focused on some of their interests. A lot of these focused interests are going to be their way to be successful as an adult. So this is really fun to dive into those special interests. Some of the really good vocational counselors do a really good job with this. So thank you very much for the time and the interest in this topic. I went a little bit longer than I wanted to, but we do have a few minutes for questions if there are any questions in the chat. We are going to be making it possible that I can answer questions if you send them in if we don't have time. I think Libby is going to make it possible for me to do that. So
correct.
All right, Libby, you're on the call. All right. I always worry that I might have been talking for like 50 minutes and I lost my connection or something. But the fact that you're still here makes me think that you heard me. So that's good.
I so appreciate you doing this presentation today. And every time I listen to you, I learn so much. So it's exciting. We do have a couple of questions. Could Dr. Stobbe speak about the lighting he referenced in the first study? And I know you talk a little bit about, in some of your presentations that I've seen, about setting up the office environment and thinking about things a little differently. If you could just speak for a couple minutes about that, and then I have another question for you.
That's great. I actually have a really cool little set of slides that one of my psychologist colleagues made that I could share that we could share with the group. But I think it's the lighting is a big one. I like to use not the fluorescent lighting overhead, but either ambient lighting or also having a you see some of the psychiatrists they'll have the a standing lamp or something like that. So lighting alternatives, and I think it's a great thing to ask at the beginning, because again, I think it shows your interest in knowing their lived perspective, and I think so that's a big deal. But it's interesting about things like waiting in the waiting room. I had a patient that had a very severe tremor of their mouth, and they couldn't get dental care without treating the tremor. And so we were trying to get them into ENT to get Botox of the oral muscles. And they scheduled the individual like at the end of clinic. And so they had like to wait for 45 minutes because the docs were late and they couldn't make their appointment. But this office was great. They reached back to the family and said, let's schedule you next time as the first appointment, so you don't have to wait. So just these little things, asking the family or the caregiver, what can help the individual get through this visit? Should we go ahead and use the iPad now? And I can observe and watch the interaction. I've done visits out in the car. I've done visits walking around the block. Asking like, what could we do so that I can buy more time and interaction and get on the good side with this individual. So I think taking cues from the caregivers is always a good idea.
Always a good reminder to be adaptable.
Yes.
There's another question in here. Would you recommend using lithium for this population?
Great question. So I didn't have lithium listed in the one slide that I had, the anti-epileptic drugs, but yes, I think lithium is very good, in the classic form of bipolar disorder. When we're talking about this population, we are thinking about them as atypical mania, atypical bipolar, where it often has this very abrupt onset, offset of changes in mood or changes in behavior. And I think that as a neurologist, lithium has always scared me. So I go to lamotrigine and valproic acid before I go to lithium. But the psychiatrists that I work with use lithium quite a bit in this population, and at doses that typically don't get into. They're not the micro doses that you see some of the naturopaths use, but they are kind of doses in the 300 to 1200 milligram per day range. That still needs blood test monitoring, still has potential, scary side effects. So that's always the thing. You always have to remember about this population. If you're going to use a drug like an antipsychotic, lithium, some of the anti-epileptics, reminding the family this is going to need blood draws. So if this is an individual that you can't get blood draws, that's going to limit your use. But yes, I would put lithium on the list of something to consider.
Perfect. And the last question is quite loaded.
Good.
As we know, there are very limited inpatient beds for adolescents with IDD and DD for acute stabilization. What are some of the circumstances where a child would benefit from a brief hospitalization versus other interventions?
Yeah, I think the benefit for a brief hospitalization is to rule out medical conditions. So I think that is the number one reason for a 24 to 72 hour hospitalization. I think the other benefit that comes from that then is often connecting with social work, letting the managed care organization recognize the severity of the condition, so that you can get everybody linked together during and develop a stronger plan going out. So I think that's I think the medical rule out, and then getting the team together, you know, with coordinated care. I don't think it's great for doing psych med management. You know, often individuals come in and, oh, they're fine here, you know, and we don't see those behaviors, or it's just not enough time. But it can at least be a way, again, to get coordinated care, to get psychiatry connected if they don't already have psychiatry connected and outpatient. I'm glad, Libby, I'm glad that was the question, not the longer hospitalization that we have nothing to offer for in Washington State. You know, so that's a topic to talk at another time.
Yeah, we're at time. Thank you, Dr. Stobbe, for all that. A lot of information in that presentation that I know people can reference back to. And then there are questions about resources, so we'll try to put those together and get those out to folks if they have follow-up questions. So thank you, everyone, for sticking around. If you want to, Dr. Stobbe, advance to the next slide. For day one of the summit, so this concludes today. We have day 2 is starting tomorrow at 1 o'clock. So here is the agenda, and if you want to register, there is a separate link to register for day 2. We will also be sending out at the end of the summit an evaluation. And again, we would appreciate your feedback on these presentations and the summit as a whole. So with that, we're going to conclude day 1, and we hope to see you tomorrow.